Bismillahirrahmanirrahim. First of all, I would like to thank the audience for waiting this late hour of the day after a heavy day. And I would like to thank Roche Company for organizing this scientific symposium that would help us all to refresh our knowledge in various and important topics in oncology. I'm going to continue after my dear colleague, Professor Ahmad Hamada, and my talk would be concerned with the role of anti-angiogenics in the treatment paradigm of ovarian cancer. Actually, I will try to give a hint on the bevacizumab. Bevacizumab, as most of us know, is a humanized monoclonal antibody that binds to and inhibits vascular endothelial growth factors. Bevacizumab reduces tumor burden and reverses ascites accumulation in mouse model of ovarian cancer. However, bevacizumab has proven efficacy in a variety of tumors, including the colorectal, lung, breast, and renal cell carcinomas. As regards mechanism of action of the bevacizumab, actually beva binds to vascular endothelial growth factor receptors and prevents its binding to the target receptors, and thus the VEGF pathway signaling is interrupted and not stimulated. That may result in apoptosis and increase the cell survival. Apoptosis is increased while the cell survival is decreased due to reversion of VEGF receptor signaling. This will result finally in decrease in epithelial cell proliferation and also decrease in tumor angiogenesis. We are going to go through the clinical trials who studied the role of anti-angiogenics in the management of ovarian cancer. We'll start off the gynecologic oncology group, GOG-0218 trial. This was a phase 3 trial of bevacizumab as a frontline therapy of epithelial ovarian cancer, primary peritoneal tumor, and fallopian tube cancer. Patients were considered eligible when they have had a stage 3 optimal or suboptimal disease, as well as stage 4 patients. This study was planned to recruit about 1,800 patients. Patients were randomized into 3 treatment arms. In arm 1, patients received the classic carboplatin paclitaxel regimen with a carboplatin dose of AUC 6 and paclitaxel dose of 175 milligram per square meter, day 1 of each 3-week cycle. And from cycle 2, they started to have placebo for 22 cycles. While patients in the second arm received the same chemotherapy doublet with the addition of beva at a dose of 15 milligram per kg starting from the second cycle through the 6 cycles, and thereafter were given placebo for 22 cycles. In arm 3, patients received the same 6 cycles of the doublet carboplatin paclitaxel, and they started from the second cycle beva at a dose of 15 milligram per kg for 22 cycles. However, treatment was interrupted if there is disease progression of intolerable treatment-related toxicity. The primary endpoint of the GOG-0218 was progression-free survival. However, in this trial, disease progression was based on RECIST criteria, as usual, global clinical deterioration, or CA 1 to 25 level. The secondary endpoint of this trial was overall survival, safety, quality of life, as well as correlative laboratory studies. To summarize, patients were considered eligible for the GOG 0218 trial if they have a diagnosis confirmed of epithelial ovarian cancer, primary peritoneal or fallopian tube tumors. Patients should have a surgery, surgery with either optimal or suboptimal debulking disease, and the stage 4 disease was allowed. Patients should have no prior chemotherapy, should at least have a duration of 1 to 12 weeks passed after the initial surgery, a GOG performance status of 0 to 2, and of course they should have no history of significant vascular disease and no history of intestinal perforation, and all of the patients should have a written informed consent. The baseline patient characteristics in the 3 treatment arms all through the trial were well balanced, and there was no differences between any subgroup analysis, mainly the degree of surgery and residual disease, as well as the stage of disease as we see. As regards adverse events, actually the known adverse events of bevacizumab were seen with a higher incidence of hypertension that was found to be actually statistically significant in patients receiving bevacizumab as compared to placebo, and about 2.4% of patients discontinued treatment because of this complication. However, all other complications as vascular thromboembolic attacks or GIT perforations, neutropenia were more or less comparable, with no significant difference between the bevacizumab arm as compared to the placebo arm. Now we will skip this. And we want to go through the data of the GOG 0218 trial. The final overall survival data showed that the median overall survival was in favor of the bevacizumab containing arms. However, that difference was not found to be statistically significant. And on update of the data from that trial, we find that the progression-free survival here, it appears to be statistically significant with the bevacizumab arm, reaching a median survival time of 14.7 months in the bevacizumab treated patients compared to only 10.6 months in the placebo arm, with a hazard ratio of 0.70 in favor of bevacizumab. And as regards the overall survival, these are, as we just mentioned, 43.8 compared to only 40.6. However, the failure to get a meaningful improvement in overall survival in this situation was due to the longer post-progression interval and the lack of control on subsequent therapy and the crossover of between the anti-VEGF factors. We may move to another important trial concerning with the issue of the incorporation of anti-angiogenics in the management of ovarian tumors, the ICON 7. Excuse me, please. I'm interrupted from the last, okay. The ICON 7 is a randomized open-label phase 3 trial. Patients were considered eligible to be included in this trial if they have a stage 1 or 2A disease but with a high grade or clear cell histology, or those with stage 2B through stage 4 regardless of any variables. This trial included about 1,528 patients who were randomized to receive either carboplatin at a dose of AUC 5 or 6 plus paclitaxel with the standard dose of 175 milligram per square meter, day 1 of each 3-week cycles, or the same regimen with the addition of bevacizumab from the first cycle through 12 months at a dose of 7.5 milligram per square meter of a 3-week cycle. Of course, treatment is discontinued if there is disease progression while on therapy or intolerable treatment-related toxicity. I would like to highlight here that the ICON study population included only patients who had undergone surgery with the aim of maximal debulking and no planned further surgical debulking before disease progression was allowed. The primary endpoints of the ICON 7 trial was progression-free survival as detected by the RECIST criteria, and here, in contrary to the other trial, the GOG trial, the CA125 elevation alone was not defined as disease progression. While the secondary endpoints were overall survival, response rate, toxicity, and most importantly, quality of life issue. As we can see here, the baseline characteristics in both treatment arms were well balanced or nearly identical to each other in terms of staging, histology, and medial age. Tumor grades were also comparable in either arm and the stage of disease at presentation. Let's skip this trial. We go to the efficacy data of the ICON 7. Actually, the ICON 7 have shown significantly increased progression-free survival in patients receiving continued bevacizumab therapy with the control group, with a median progression-free survival reaching 19 months in the beva arm compared to 17.3 months in the chemotherapy alone arm. And this was found to be statistically significant difference. On the forest plot subgroup analysis of progression-free survival, it was in favor of bevacizumab containing arms all through the items, all through the subgroups. The ICON 7 here had raised definition of high-risk patients. According to the ICON 7, high-risk patients are those in the pink color, those with stage 3 disease and irresectable tumors, or with a big tumor residue after surgery, and patients with stage 4 disease regardless of any other criteria. We will see here the impact of risk categorization on the outcome of therapy for patients with ovarian cancer. And here the updated analysis of ICON 7, we can see that progression-free survival in high-risk group was actually higher with a median of 16 months. Here the curve widely separate compared to only 10.5 months in patients receiving chemotherapy alone. And also this improvement in progression-free survival in high-risk subgroup of patients was translated into improvement in final overall survival that reached here 39.3 months for the beva containing arm as compared to only 30.3 months for the control group, with a 9.4 months benefits of survival, absolute benefit between the two treatment groups, and of course in favor of the bevacizumab containing arm. Here, this figure summarizes the difference. Here, there is no clinically significant difference concerning the overall survival in the low-risk groups receiving bevacizumab as compared to those receiving chemotherapy alone, while the curves here separates in the high-risk groups with an overall survival benefit significantly higher in favor of the bevacizumab containing arm with a difference of 9.4 months between the two groups, with a high hazard ratio of 0.78 in favor of bevacizumab containing therapy. As regards all adverse events, there was no new reported adverse events apart from that well-known concerning the bevacizumab therapy, mainly the hypertension and the bleeding tendency that was mainly of grade 2 mucocutaneous. Otherwise, there was no statistical difference in the adverse events. These are the grade 3 adverse events consistent with previously bevacizumab, and as we mentioned, here is the hypertension, of course, higher incidence than the others. We want to go back again for the final overall survival, and as we have mentioned, it was in favor of the bevacizumab as this first plot analysis here in the high-risk groups, while in the non-high-risk groups, this advantage was lost. Therefore, what to conclude from the ICON-7 study? Actually, there was no overall survival benefit in the entire group collectively, but with further subdividing and categorizing patients, those with high-risk groups have a significantly overall survival improvement with the bevacizumab 7.5 milligram per kg compared to chemotherapy alone, a 9.4 months median difference with a hazard ratio of 0.78 was in favor of the bevacizumab difference, and therefore, here in such a situation, overall survival in high-risk group of patients was really meaningful. To collect the data from the ICON-7 and the GOG 0218, actually frontline bevacizumab with chemotherapy followed by continuation single-agent bevacizumab alone prolonged progression-free survival in women with ovarian cancer. Bevacizumab treatment was generally associated with manageable side effects and no new safety concerns. Analysis of high-risk patient subgroups in ICON-7 supports the use of bevacizumab in women with stage 3 or 4 ovarian cancer with a macroscopic residual disease. Carboplatin paclitaxel plus bevacizumab and then continued bevacizumab therapy could be a standard frontline treatment option for advanced ovarian cancer patients. And finally, I would like to thank you for your patience and attention. And it's now night at Cairo, and we are no longer in the morning.
Thank you, Professor Ibtissam Saaduddin, for this very good presentation. And I think we are behind time. We have just have time for a couple of questions. Dr. Tamer.
Thank you, Professor Ibtissam, for the informative presentation again. Well, it's very obvious that stratification of patient, especially
Please,
with
the voice.
It's very obvious from the speech that Beva is better in patient stratified as high risk. So in lung cancer, we did have a lot of research on biological marker like VEGF level in blood to stratify patients who might benefit more from Beva. Does the same apply to ovarian cancer, yes or no? And thank you again.
Actually, the situation in lung cancer is different. It has been heavily studied. However, so far, the high-risk group of patients to make benefits or meaningful improvement in overall survival or progression-free survival as those identified by the ICON-7. That's to say, patients with irresectable stage 3 disease or those with a big residual after surgery and patients with stage 4 disease. If you are asking about, we can, biologically, we can, there would be a biomarker to select patients who may be appropriate for this therapy or not. I think this needs a randomized trials to give you an accurate decision, not defined accurately.
Actually, I have a comment to Tamer. I don't know if this is luck or not, that I read this paper just today in the morning, that there is actually a trial done in the ESMO for a new drug that it is anti-TKI for vascular endothelial growth factors. They randomize the patient to the level of vascular endothelial growth factor level, and they found that the survival or progression-free survival doubled when the level of vascular endothelial factor halved. So there is a trend.
Actually, we're speaking about ovarian tumors and on the bevacizumab drug specifically. There should be a trend, but there is no, up to this moment, a clinical randomized trial to give us a firm conclusion. Of course, there is a hell of research in this subset because it's very important, but up to this moment, we don't have randomized trials to give us firm conclusions.
This is a randomized trial.
Yeah, but this is not concerned with the ovarian cancer and not
this
this
is
sitting.
This is ovarian cancer, but not on VEVA.
Not what? Not on bevacizumab, but that's not
on VEVA.
Okay, we are talking about the bevacizumab, and that was the topic of the session. I have answered Tamer because to give him a firm conclusion, I should have also a firm data from randomized trial in the same subset group of patients with the same drug. Of course, if you have similar drugs, right. I know you can go parallel, but you cannot say, these drugs are doing okay well.
If I understand the question of Tamer correctly, he asked about if there is a biomarker. Yes, there is a biomarker.
There is, but he said if we can select the patients of ovarian cancer according to this biomarker to receive bevacizumab or not. Was his question.
I agree totally with you, Dr. Abdeslam, that up till now there is no validated biomarker for BEVA in any solid tumor.
Yeah.
In any solid tumor. And by the way, if the marker is elevated, it is not legalized to be used, because the use of the test to be validated need what is called high sensitivity and high specificity.
Of course.
If we know that the MRI of the breast, for example, is a highly sensitive tool, why MRI of the breast is not used instead of the mammography for screening? Because MRI of the breast lacking the specificity compared to the mammography nearly 90%. If you do the MRI of the breast for all the women, there will be increased number of false positive biopsy. That's why for the test.
I do agree with you, Professor Fouad, absolutely. And of course, we go to the guidelines and up to last version of this year, 2014, there is no such
validated marker,
use of biomarker for the use of bevacizumab in ovarian cancer, and this is up to this week on the NCCN guidelines.
That's right.
Thank you.
Okay, I think we come to the end of this session. Thank you, Professor Abdeslam.